partners here would perform a laryngectomy. It's very interesting.
We are missing the imaging.
Yes,
yeah, today we are missing the imaging, which is very important, I think, for laryngeal cancer.
It's invading the cardiac.
Yeah.
Maybe we have
is the invasion of the
N3 metastasis.
If the invasion of the cartilage, total laryngectomy.
Okay. It depends on the lymph node involvement.
And also, both on the lymph nodes and also on the local invasiveness.
Yes, you see in the slide, it's locally invading through the cartilage in the.
No doubt, total laryngectomy neck dissection.
Okay, you have a comment?
Well, I think it will work. Okay. For the last patient, I think the swallowing function test is very important. If the patient is aspirating already before treatment, I would be very worried to have a larynx preservation treatment strategy. So, but coming back to TPF, I just want a clarification. I think in the GORTEC study in larynx and hypopharynx, there was no survival advantage.
No.
So the difference is only larynx preservation. So I think your subset analysis, Marshall, is not confirming the GORTEC data. It's different than the GORTEC data. So,
well, we included an inoperable population, the GORTEC trial, and so in the operable patients, there's no survival advantage because you can salvage patients who have progression. So that is why in organ preservation studies, it's hard to demonstrate a survival advantage without
I think it's hypothesis generating, so it is different from GORTEC data because your patient population is different.
Yes.
And probably the salvage strategy for salvage may not be as aggressive as in other studies.
So when we want to give the audience a take-home message of this session, what should we say? Should we say 9111 is now the standard? We have to wait on your results. If TPF will bring better local regional results, better larynx preservation, better larynx-free survival, we have to wait for this, for the results. And surgery in surgery we perform as salvage treatment, not anymore as primary treatment. What think your final result?
Well, if I may say, I think that on the basis of the data that we have at the moment at hand, we cannot make a final statement what is the best approach for organ preservation. And I think that further studies need to be done in order to make that assumption. And so there are different approaches that could be used, and what is the most optimal, and also with respect to late side effects, I think still has to be discovered in next trials.
That's right, and I think we have to recognize that we individualize the performance, and not everybody is an organ preservation candidate, whether they have the same stage or not. And we have to look as physicians at whether the patient's capable of rehabilitating. The chemoradiotherapy is clearly the most damaging and difficult of the treatments. The most long-lasting side effects occur from that in terms of diminution of function. And if we have a patient who isn't going to be able to swallow afterwards, or who's going to be aspirating, which causes significant death and morbidity in the patients, then we have to seriously think about whether early laryngectomy or laryngectomy is the standard for those individuals. So a dysfunctional larynx is not going to be salvaged. A completely dysfunctional larynx that's destroyed is not going to be salvaged by either induction chemotherapy or chemoradiotherapy. And I think that's a lesson that we learn.
Do you want to make a final statement? You have introduced, and you can
well,
the last
I'll just say
now.
that I think we've treated thousands and thousands of patients with the 9111 regimen, so we have lots of experience and lots of data with it. And I think we just have to be cautious about using ad hoc therapies that actually may produce inferior results. So I'm enthusiastic about moving forward with new trials that test these new therapies.
I have a question.
I think now we I think we can discuss it during the coffee break with the people here or under each other.
Well,
but we at the end of time.
She won't be up here again. So I have a question for her. Are you pursuing a comparison of induction chemotherapy with TPF or some other set of agents compared to chemoradiotherapy? Is the RTOG or the intergroup doing that at all? Is that in the works?
There is international discussion going on about formulating a new study.
I would think it would be an important question to address.
Okay,
Yep.
so now we are waiting for the next studies. Maybe in 2 years we have to discuss more. I thank you very much for your participation, and we will come to the next session then.